jointly supporting the delivery of our GIRFT programme across our system. And this, as I say, is our ophthalmology event. So thank you very much to all the clinicians, managers, service improvement leads for your time today. But also thank you to our regional and national supporting colleagues. So hopefully we've got Ian Ellis, who's our GIRFT regional lead, and Alison Davis, who's the national GIRFT lead for ophthalmology. Thank you, see you there, Alison. Welcome, and thank you very much for the time to come today to help us on understanding GIRFT could help support us with for our patients and our workforce as well, and our whole system. That's really important. So we want to, today is the part of a process. It's, we are resetting and recovering following, as you all know, the pandemic, and we're trying to get our services back to where they were and continue to improve them. The reset part of this is about using this as an opportunity to implement the pathways, the services, the things that we've always wanted to do, but maybe have struggled to do previously. This is our opportunity whilst we're resetting and recovering our services. So I encourage you all, please, to engage today. There's obviously going to be some talking at the beginning. We want to open up to the ophthalmology clinicians to sort of, what are your big issues at the moment? What are the big things that you think in our system could improve? We want to capture those, and then obviously go on to let the national lead describe what's happening elsewhere. What's best practice? What could we adopt? What should we adopt? And what could we do for our system to improve? So we've got some time today, protected time, to do that. It's good to see so many people joining, and this is the third event, I believe, Emily, we've had on GIRFT. We've done trauma and orthopedics and neurology, and I have to say the attendance from the system has been excellent. It just shows you the enthusiasm and passion for continuing to improve services, which is really welcomed. So that's an overview and introduction. So I think it would be really helpful, I think the agenda's taking us that way, if some of the senior clinicians from an ophthalmology background would use this as an opportunity to give us those big issues that you think we should be tackling as part of a getting it right first time programme, but also a service improvement for our patients. And we'll try and capture those before we ask Alison to come in with a sort of national perspective. Is that okay? So any of the ophthalmology consultants or senior nurses or anyone wants to come in, just raise your hand. You're all very quiet today. Dr. Sharma, that's good. Hello, Dr. Sharma. Thank you.
Thank you, Mary, and thank you for the GIRFT team. If you don't mind it, I would like to probably share my slide if I can show. Can you see my slide now?
Yes, we can. Yeah, that's helpful. Thank you.
So, you gave us, I will take about 5 minutes if it is all right, just what we are finding that key problems and what we would like from GIRFT as well. Okay. So you ask us to give us the challenges. Challenges are basically backlog in medical retina and glaucoma, and related IT issues, and also the cataracts. So most of the people, when they look at ophthalmology, they worry about the outpatient waiting times and worry about the cataract surgery. In Worcester, we had created a diagnostic hub thanks to our excellent support from our trust management, who provided extra almost £250,000 funding, and we set up this diagnostic hub well before Moorfield Eye Hospital. Actually, we set this up in July 2020, and with digital platform, we are improving it. The key issues we are finding it difficult is how IT systems are talking to each other, because that is delaying our capacity to review these things and fail safe all the waiting lists, etc. So IT is one of our big challenges. Another big challenge is private providers, which are coming and taking a bigger share of market. And if I'm just showing this graph, can you see the graph here?
Yes, we can. Yeah.
If you can see the graph, you can see the cataract referrals have been going down well before the COVID as well. And the reason for that is, at the moment, there is a system of fake news, and there is no way to protect that, or no way to challenge that. because opticians are given perverse incentive by private providers because they get some fee to do some kind of a assessment beforehand. And that's why they say, oh, NHS, you've got a waiting list of 60 weeks, while it has never been 60 weeks in our place. And this created a system of imbalance in the overall scheme of health economy, because there is one patient who may get the cataract surgery in 4 weeks because he has gone to that private provider, while others are getting it 44 weeks. So again, we have to also think why we should have different system for or different waiting times for different procedures. Why cataract surgery should be offered at 4 weeks at the expense of perhaps a hip replacement, where hip replacement which is waiting much longer. So overall scheme of things, we thought what should happen, and that's what we have implemented now, that in Worcestershire this is going to happen. And I think this is a great idea, which perhaps, hopefully, GIRFT, Get It Right team can take it to the national level as well, that there should be one gatekeeper for all cataracts in a region. So in our region, our commissioners have been very helpful and they were very understanding. They have agreed to have a one gatekeeper, and where everybody is referring the cataracts, and that gatekeeper allocates the patient according to the patient choice, which we have asked patient to list 1, 2, 3. These are their preferred choices. But obviously, the most important choice is the choice of time, and the time is given to them, and then that will deliver the same waiting time for cataract across the region, and hopefully, ultimately, across the national level. And that should definitely help the problem that will give incentive to the NHS Trust to reduce their waiting times as well. And this transparent system will have a correct prioritization of cases, will have equal waiting time for all, will have full utilization of NHS capacity, will have appropriate utilization of private provider. There will not be any funding gap for commissioners, and it will be timely in-house management of complication. Another thing which I Get It Right team perhaps should take at national level and discuss at a bigger level, that why the tariff to a private provider is the same when they do not provide any training, when they do not do any complex cataract. Whatever we may say, whatever private provider may say, we all know that the NHS trusts are increasingly left with much more difficult cataracts to do, which are difficult to position, difficult to do this. When as soon as they pick up this could be a difficult cataract, they just send it to us, which it requires much more equipment. We need to use Milligan ring, we need to use Helon GB. We're using so much of equipment that we make a loss, while private providers doing a cherry picking and doing the simpler cases, they are doing at the same level. So it's, although another thing which we need to be aware, and I don't know how to get around this fact, I consider optometrists are a very important part of the team, but there is a risk of paying too much for unnecessary OCTs according to the newer schemes, because and if it is any OCT it is done, if it is chargeable, we need to create a system. And what this has temporarily caused some increased referral as well, because they do an OCT, they find, oh, this is wrong. Like in glaucoma, you can see the red disease, or similarly other artifactual things which are referred, and that's basically increasing the workload for even an so that pathway needs to be tightened up. And why should they have the same OCT charge while they may have an OCT for 25 to 28K, while we have to invest with OCT, with NGO, and with all the different facility which cost in excess of 180K. So these are the things, in addition to get right the systems right, we need to make sure. And in an integrated care system, we need to find the correct balance between even different geographical regions like Hereford and Worcester. We have a very good relationship with the Worcester Hereford team, and hopefully we'll be able to work. But ICS rules needs to be defined even more carefully. So in Worcestershire, where we have tried to set up this cataract gatekeeping role. We have got a glaucoma coordinator, we've got an AMD coordinator, and we have got the urgent community eye service facilitator. So we are working with the thing, but key things is how we manage our relationship with optoms, how we manage the relationship with independent providers like New Medicas or Spa Medicas, and the shared care model, which we are doing, how IT is talking to each other, And these are the key challenges which we are facing, and hopefully we'll be able to listen to more solutions. Thank you.
Okay, thank you. For those of us not as close to the ground as that was really interesting. And I know there's been a lot of work on ophthalmology across the system for many years now, but that was helpful overview and something for us to think about as we go on this journey. Welcome views from Wye Valley. If anyone from Wye Valley wants to bring up any particular issues. Got anybody on? Is it Dr. Smith? Sorry.
Alaric Smith, Mr.
Alaric
Smith.
Yeah.
Hi. Thank you very much. Thank you, Mr. Sharma, for a nice presentation. I apologise, I've not provided any slides. Just in terms of our challenges, COVID has really set back clinics and particularly follow-ups. As a medical retina consultant, I'm still being asked to triage patients who have not been seen or have due dates to be seen in early April of 2020. So it's still a big challenge to try and catch up with some of those. We've been prioritising through the whole COVID period of the urgent care, and we have set in better processes for urgent reviews. We've put in more virtual clinics, but a lot of this is on the background of challenges to the trust from other services, and there's little time to actually put into to formally commission services across the CCG area. So, for example, I know that before COVID came in, I had discussions with colleagues in Worcester about setting up hydroxychloroquine screening, and effectively we're doing this, but it's not a commissioned process. We're seeing these as new patients each time. Obviously and requesting a new patient fee for it, and this work is coming on me as a sort of as a consultant responsible, whereas actually we could be employing people to do this. It's a service that perhaps optometrists could do, but you need that sort of proper screening sort of hub. You need the database, you need the call and recall, you need the fail-safe to be put in place, and that's not in place, certainly in Herefordshire. We're doing more virtual diabetic clinics because we just don't have the capacity to see all these patients in clinic. We lost physical space in the eye unit during the COVID period to A&E. And whilst we've gained some of that space back, and we've tried to use adjacent spaces more effectively, it's very difficult to be efficient in a service where ITU have taken the space where we normally book patients for cataract services. We're having to use vision lanes for holding cataract patients. Which means that we can't do appropriate vision testing for clinics in an efficient way, which puts backlogs on clinics. So we're really in a position that we don't have the physical spaces, and alongside that, there are issues with nursing staff. There are a lot of people who've been on sick leave or shielding during COVID, and people who've decided to leave the service. So we're in a position that we don't have a sort of fully trained nursing workforce. We're short on imaging staff. We've lost nurse injector staff. We're having to put doctors in to do injecting lists where we should be using nurse injectors. We're trying to train up new nurse injectors, but there are challenges throughout on all of these pathways. And I think that, you know, the big challenge to us is space, lack of theatre capacity. We could do with 2 operating theatres instead of 1. We could do with a sort of a purpose designed bespoke injecting unit instead of just our mobile unit, which is outside of the hospital trust, just outside the front entrance as a standalone unit, plus whatever rooms we can use inside. So, you know, we are sort of trying to face challenges, but there's limited resource to put in those, you know, real the real solutions that we need in terms of physical space, staffing, and so on.
Okay, thank you. Thanks. And just to commit to you, because we're obviously, I should have said at the beginning, sorry, we're recording this session, and what we'll do is we'll pick out the high level issues that have been raised and obviously use that as the baseline for any improvements we want to make. Where are we now, and what do we want to see in the future? So, you know, I recognise there's a lot there, and COVID has hit, you know, has made a big impact on everything, hasn't it? So, you know, we will keep those as our sort of baseline of things that clinicians have said need to be improved or altered, and let's hope we can use some of the GIRFT work to help resolve some of those issues. Okay, so thank you both, that's really helpful. So anybody else want to come in before we move on to Ian Ellis, who I believe is going to present a sort of GIRFT approach, etc. Okay, thank you, that's great. So Ian, I believe you're taking over, is that right?
Yeah, I'm going to share the screen. Alison's going to talk to start with, and then I'll come in afterwards. So I hope that I get the right screen here. Oh, no.
Yes, that's. Can everybody see the slides? Can
Yeah.
Oh, no, I've lost them.
It's back.
Okay.
Right.
Yeah, they're back with us. So I think, thank you, and it's lovely to hear from Taryn and Ulrich. I did the Hereford deep dive visit 3 years ago, and I was looking at Carrie's notes from Worcester. And despite everything, it's really interesting and great to hear about the progress you've made, and certainly in terms of answering some of the exam questions I've just been set. We'll come back to those in the course of the session. But just to say, by way of reassurance, I think what's really, really important, previously we've just really looked at RTT data, which is only the tip of the iceberg in terms of the story for ophthalmology, because it only tells us about new patients. And I think, as both Taryn and Eric have highlighted, for us in ophthalmology, we have a real worry about our long-term follow-up patients, particularly for both glaucoma and medical retina, which is a real area of focus for GIRFT, because particularly for patients with glaucoma, because they're asymptomatic, they will lose their sight and go blind if we don't see them regularly. COVID made matters worse, as we've heard described, but also it's a real opportunity for change and a catalyst to actually reset. So, as well as the GIRFT National Report, which is on this slide, there's there was a National Outpatient Transformation Programme, and all of that has been brought together in one umbrella in terms of the National Eye Healthcare programme. So there are increasing resources to actually help people to move forward. So we don't all have to start from the beginning in our own area. So there's lots and lots out there. I think for those who are not versed in the sort of the provision of ophthalmology on a day-to-day basis, I think there are 2 points that are really important to make. One, cataract surgery is the most common operation in the NHS, and in terms of outpatients, the ophthalmology is the largest NHS outpatient service. If you can show me any hospital anywhere where the largest outpatient facility in the hospital is the eye department, I'd love to see it, because we didn't find it on our deep dive visits. So the only thing that's small about ophthalmology is the eye. Everything else is big. So if I could have the next slide, Ian, please.
Yeah, I'm going to try and make this bigger, actually, Alison.
Right.
While
Thank you.
So I'm just going to take you through some of the work that's been done to date, then we've got the metrics, and I'm just the metrics is an Excel spreadsheet, and we can talk through some of them, and I think really highlight we thought 5 key actions that would be useful for you as a system to think about. So firstly, the high volume, low complexity pathway is focusing on the work streams that you can see. So in terms of ophthalmology, in terms of eye care, we've absolutely got a moment in the sun. In terms of the planning and priorities letter for 21-22, ophthalmology eye care is a key focus. So at a national, regional, system, local level, there is, we are all required to put in place, in fact, all the things we've all wanted to do as clinicians for a long time. If I can have the next slide, because I'll come back, I think, to this point in a moment. So if I could have the next slide, Ian, please. So in terms of cataract surgery, when we think about this, it's very easy to say high flow, low complexity. Well, let's just look at the number of cases on a list. But the reality is, and I don't know if Melanie Hingeron is on the call from his colleague on the national team, and we previously worked together at Moorfields. Actually, you can't have high flow on the day unless you have robust pre-assessment before the day. And equally, we've got to have the right patients referred to us at the right time who want surgery, as I think Taryn very clearly articulated in his presentation. So there's something about conversion rates, and we know that there was a significant unwarranted variation from our GIRFT deep dive visits. Looking at how then we get really robust pre-assessment, and I'll come to this in the next slide, and then post-operatively, what we are recommending is that the majority of patients who have uncomplicated cataract surgery, their post-operative visit should be in the community, with data flowing back in terms of refraction and acuity data, so that we can check and understand the services being run at a high quality from a governance perspective. You can see, so that's from a GIRFT and then the National Patient Transformation Programme. And I think I'm not going to go through all of this in detail, you'll get the slides, but it's that absolute point that we're all in this together. We can't, as ophthalmologists in the hospital, do everything that we need to do without our optometry colleagues in primary care and in the community. And I remember when I came to Hereford being talked through, that's a really strong relationship, as I remember, with the optometry colleagues in the community at that time. Next slide, please. Okay, so this is the cataract pathway, and just by way of where did this all come from? This work began in London for no good reason, and that's where we were asked from a GIRFT team to start last May, actually, nearly over a year ago now. And we spent about 6 weeks or so every week with a virtual room of at least 30 clinicians. So again, ophthalmologists, optometrists, pharmacists, nurses coming together to say, what is it that we think we could collectively put together to create high volume, low complexity lists? And very importantly, risk stratification is a key part of that. And I think in answer to Taryn's question about the independent sector, there's got to be absolute transparency. And I thought your model for gatekeeper or triage, which is called in other parts of the country, is absolutely spot on. So everybody knows exactly what is and isn't being provided, exactly what is and isn't commissioned. So they're the elements of this. So in amongst all of this, there is a point around training, because whether you're working in the NHS or the independent sector, our vision for the future must be that we have teams of people who can deliver high quality, high volume cataract surgery for patients who have low complexity. And that isn't just the surgeons, that's nursing colleagues, the whole theatre colleagues, it's the whole team. But we need to move beyond the independent sector not providing training. Next slide, please. If you go back, so that's just highlighting the London programme, and there are 6 work streams, and so you've heard mention orthopaedics and urology, also ENT, general surgery and gynecology. Next slide, please. And then for glaucoma and also for medical retina, again, in-hospital and post-hospital recommendations. And it's this key point about only having people being seen in the hospital face-to-face by clinicians, whether that be nursing colleagues or ophthalmologists when they absolutely have to, and doing everything we possibly can to avoid patients attending the hospital. So we're doing lots of work at a national level in terms of developing pathways. So you've got a toolkit, so you can just sort of say, okay, this is a potential toolkit. How do we localize that to make it make sense for us? And the point about IT connectivity is mission critical. You need to have all your systems connected. From a GIRFT perspective, we're always agnostic in terms of platforms and what we suggest, because there are a number of different ones. But I do remember going to a deep dive visit in another part of the country where clinicians were running up and down the corridor to look at images so that they could see their patients, which is never going to work to run effective and efficient pathways. Next slide, please. And similarly for medical retina, and we'll come, I think, back to this a little bit more when we look at the gateway metrics, but Ulrich, you mentioned hydroxychloroquine. Absolutely, you're completely right that we really don't need to have doctors seeing those patients for hydroxychloroquine screening. That is work that can be done with the appropriate training and governance with our optometry colleagues, making sure you have an OCT screening pathway for particular diabetic maculopathy M1 to reduce by half the numbers of patients for that particular cohort who actually need to attend a hospital appointment. Next slide, please. So in terms of, this was the approach that we took in terms of high volume, low complexity. Whether we think about surgical hubs, which may be the right thing for large urban areas, or whether we think about surgical or networks, and which may be more appropriate. Certainly, I'm now working in East Kent, which was certainly something we would think of in East Kent, or I suspect in Hereford and Worcester. But it's having key principles which are the standard, and then the geography is not the important bit, it's the pathways that are important. And as I said, it's the same for everybody, whether you're in the NHS or the independent sector or community provider. Next slide, please. Ian, you're going to do some data, I think.
Yes. So again, just as a kind of a scene setting, I'm sure that colleagues in the system will be familiar with where you are with your waiting times data. This is obviously just looking at the validated data that is a bit behind the curve in terms of timeliness, but it shows that from a regional position, the Midlands has the largest number of over 52-week waiters for ophthalmology of all 7 regions in the country. And that's in terms of all incompletes and those with a decision to admit. And as you can see, the London region has the lowest number of waiters based on the March 2021 data. And a lot of that is due to some of the work that has already been done that Alison's alluded to over the last 9 to 12 months within the London region, things like Moorfield's Cataract Drive, of which there's the example there, and the work that has been done at Epsom and St Helier Trust around their cataract hubs as well, to try and reduce those long waiters down by using things like mutual aid, cataract drives, and by having surgical hubs that are available to work. Just then changing that up so that it shows the data by our region and by each of our ICSs, as they're now called. You can see in there from the light grey line, which is Hereford and Worcestershire, that Hereford and Worcestershire's around about 3rd or 4th in terms of lower numbers, with other systems having much higher numbers of over 52-week waiters for ophthalmology. And then the next couple of slides are just showing for the Hereford and Worcestershire system, the waiting times of your patients spread out across a number of weeks based on the validated data in March. So you can obviously see that there's a number, this is the number of patients over 52 weeks. And then based on the unvalidated weekly RTT data that gets collected at the moment, again, a bit more of a granular breakdown of where the waiting list is at the moment. And obviously you can see that Worcester has a total waiting list probably about double the size of Wye Valley's, but when you get to the over 52-week wait position, it's got considerably a higher proportion of over 52-week waiters than Wye Valley currently has. And that was apart from your kind of P4 element as well, so that's just showing you kind of P2, P3 and P4 elements. where actually the waiting times as at the 6th of June are fairly, or the numbers are fairly similar in terms of each of the P2, P3, P4 surgical waiting times. But that's just to give that kind of idea of what the numbers are looking like in the system at the moment as we go into the gateway discussion. Okay, so I'm going to stop sharing my screen now, and my colleague Rachel is going to share her screen, and we'll go into the actual clinical gateway discussion, unless anybody's got any questions they want to quickly ask us.
Thanks, Ian. That's really helpful. So, anybody want to come forward? No. Okay. Thank you. Oh, sorry, Dr. Sharma.
I just wanted to make one comment there. In the data when you're showing for Hereford and Worcester and Wi-Fi trust, if you just compare it to the size of the population, those trusts, that will be a better parameter to show how each team is doing, because I think we cater for 580,000 population, while Wi-Fi trust caters for 200,000, and then that's number of clinical different services which are available, whether they are, if the number of the team is bigger, that number is likely to be bigger. That was just my comment. Thank you.
Yeah.
Absolutely.
Yeah, I was going to say, and also that's a good point, because also when you look at the size of the departments responsible for those waiting lists, it actually sort of, if you think in proportion, although the numbers might be smaller for Hereford and Worcester, that doesn't mean to say you haven't got a big problem. So I think that's a really good point.
Yeah, absolutely.
Okay,
but also the reason that we show those is whether or not there is an opportunity, despite the population differences and the service differences. This is all part of having an engagement discussion about whether there are things that could be offered from a mutual aid perspective. One of the things we heard on Tuesday in the urology discussion was that Wye Valley is providing some mutual aid for some services to Worcester. So it just enables us to have that conversation and support you to do that. Okay,
thanks. So Ian, is somebody called Rachel Davis? Yeah, put it up. That's great. Thank you.
So I hope the text on this is a bit on the small side, so I hope everybody can see this. And just before we start, I just happened to spy that Wojciech, who is one of our regional GIRFT ophthalmology leads, has joined the call. So he's the Midlands regional GIRFT ophthalmology lead, so he's here to help and support, because the structure we've put in place is still that Cameron and I are the national co-leads with Lydia Chang as our ophthalmology clinical advisor, and then we're working with each region, so you have a regional person as well. So Wojciech, please feel free to chip in as we go along. So what I thought I'd do is we'll just go through some of this, not all of this, because I want to leave. I'm going to definitely stop by 5:30 because I want to make sure we've got plenty of time for discussion. The exam question I'm going to pose to all of us and to myself as well is, what are the 3 to 5 priority areas that we really are going to think, okay, these are going to be our areas of focus for Hereford and Worcester for the next few months together. And I think when I looked at this data, what I said, if you put all the things that are really good in Hereford together with all the things that are really good in Worcester, we'd probably solve about 90% of the issues that were arising. So in terms of, we just look at cataract first, and just thinking about whole pathway, you're already using the shared decision-making aid, and that flips into and looking at, now if I've got this right, Wye Valley, you've got a 98% conversion rate. And what that importance for that for the non-clinical colleagues is, it means that only patients who both need and want an operation are being referred through and having surgery. When we started with GIRFT, we found that there was a huge range down to the lowest of 15% conversion rate for first eye cataract surgery. So that's really good. And I just think, I was just curious, and maybe we'll just pause for a moment on this point. In terms of how have you achieved that in terms of in Hereford, and just thinking about mutual aid, mutual support, for Worcestershire, it's not bad at 75%. It's a lot better than a lot of places, but just sort of thinking, how have you been successful in Wye Valley, and what lessons would you share with all of us? Because I'm also really keen to collect ideas for other areas as well. I don't know. one of our clinical colleagues, Alric. Can somebody do their hands while I'm talking, so I might miss people? But
Yeah, that's fine. I'll do that. Yeah.
Thank you. We've had a very strong relationship with our community optometric colleagues for a long time, and introduced a sort of direct cataract referral pathway, sort of bypassing GPs, and ensuring that the optometrists have a good structured sort of mechanism for referring in, particularly with that proviso that patients have been discussed, all the risks and benefits, they've received information in writing and verbally, and are highly committed to going forward with cataract surgery. And we've expanded that. I mean, this is many years of work, and that's been expanded into the post-cataract sort of pathway of optometric follow-up as well, in more recent years. So, you know, we think we're doing sort of things very well in terms of the cataract pathway and ahead of the game, largely. But I mean, obviously we are facing challenges. We've had a high RTT. One of the issues that led to that was the fact that we didn't have adequate intravitreal injection services, and we ended up doing 6 months of intravitreal injections in our main theatre for 1 or 2 lists a week, which severely set back RTT, and we never caught up from that. And this is again about sort of capacity for the whole ophthalmology service, not just for cataracts. But yes, RTT has you know, we just don't have enough capacity to deal with it. But we think we've got good pathways, and we're obviously willing to try and provide a good service.
Brilliant, thanks, Alric. So I don't know, from the Worcester perspective, in terms of the pathway you have and just making sure that you get the right, and you alluded to working with optometrists and how, because of the skew with the independent sector, that, you know, you've had to try and move on and move forward. Do you think that that approach will help things?
No, we have been in discussion with the CCG, with colleagues there, and also with the optometrists. I think possibly Hereford optometrists are more highly related to the trust than ours, and have done some work on this. And the cataract filtering service that the optometrists have offered to provide, they already provide a post-op service, so all our post-ops go to them, but they haven't been providing that enhanced screening at the front. And so that was very much, we're very supportive of their proposal to do that filtering, because that is them doing that pre-screen that will still, we do a one-stop clinic anyway for Cat Assess, but that pre-screen would stop the, would increase the conversion rate to 100%, because they would filter out any of the inappropriates. And that's realistically what we've been discussing over the last 6 to 9 months about, can we get this implemented, because that would impact immediately on that particular performance measure.
So by way of help for that, in the GIRFT best practice library, there are documents relating to the cataract pathway, and we spent quite a lot of time in London working with the local optometric committees to understand how to help and support that pre-assessment process. And the optometrists were very clear and happy to support that this would be working within their standard practice. It wouldn't need to be an additionally commissioned pathway, whereas the post-operative element definitely is. So there's a document there to help you, and I just wonder whether it might be worth, as you know, as one thing to do would be to have to gather together optometrists and clinicians from both Hereford and Worcester, and to just describe the two, because sometimes, you know, people in the past, when we were all allowed to travel, used to travel the world to see fantastic things going on and forget that down the road there's something really, really good, and perhaps don't share practice in that way. So that, I think, would be an opportunity there.
Just come in. John from Y Valley wants to come in. His hands up.
Thank you.
I'd just like to say, can you hear me? I hope the microphone's working. That it's a bit of a chicken and egg situation. So what happens first is it has to happen both ways. So the optometrists, and we've all found that through COVID, that the optometrists have a huge role to play. but it doesn't happen all at once. And it does take time, and it does take trust, and it does take willingness to proceed on both sides. We've got, and unfortunately it also takes money, because the optometrists work in a private sphere. They don't work in the NHS. They're not commissioned by the NHS unless that's set up specifically. And that's where a cataract assessment pathway from the optometrist point of view is probably quite important. And it was the first one of the things we set up in Hereford. We've since then gone on to glaucoma and all sorts of other things like the rest of the world. We've actually got Darren Smith, I think, on this call as well, who is an optometrist in Herefordshire. I don't know if he wants to say, but it does take a long time. It doesn't happen overnight.
No, I think that's absolutely fair comment. But there is definitely now working as a system-wide is becoming, the accepted norm, and it would be an unwarranted variation if there weren't these linked pathways. So I agree, you've got to start somewhere, and I think hopefully your gateway approach and so on will begin to make things feel like it's a more level playing field and how those relationships move forward. In terms of, I wasn't quite clear, in terms of risk stratification, when I looked at this, it looked to me like both Hereford and Worcester were risk stratifying cataract patients, although there was 0% for WVT, which is Vinepass, which is Hereford, isn't it? And I just wasn't quite clear why that was, because it sort of looks to me like you are doing it and it should have been 100%. Is that just a data glitch? Okay, but if it's not clear, then let's ask the question the other way. In terms of, we agreed with, there's a Royal College risk stratification document for cataract surgery. Fine to have a local one if you want, but as a starter pretend it exists. And again, it goes back to that point about openness and transparency and where patients are being seen in terms of high complexity or low complexity. So that's what we used as our starter pretend for the whole high volume, low complexity pathway. And I think for everybody, it's really important to be clear and understand what the case mix is. So for this type data, we're actually going to roll this out in a slightly different, just a slight variation to this, to ask people all units to collect this data on a quarterly basis, and then it will be fed into model hospital. And that, I would say to our commissioner colleagues, includes the independent sector. They obviously won't be providing all the services, but it's absolutely expected that if you're providing NHS care as an AQP or whatever it is, we have to have exactly the same standards. And as I said, it includes training, but they need to be completing this. So I think if you're holding the contract, that should be part of the contract arrangements. That that just is, and that's business as usual. So it might be worth just looking at that from a Hereford perspective, just to see whether or not are you risk stratifying in some way your cataracts? You must be. I can't believe you're not.
We do provide sort of P scores, if that's what you're talking about, sort of P2 to P4, etc. Is that what you're?
Not really P2. It's more what we would. I suppose it's a sort of a derivation of P2. Have a look on in the GIRFT best practice library, and you'll see within that the risk stratification. But it also it doesn't necessarily. It's not exactly quite the same as P2 to P4. It takes this more of a clinically based. I suppose a bit more clinically based. And it would show you, so then you would end up in saying, okay, as well as because you could have a P1 patient who's low complexity who could go into into the high volume, low complexity pathway, or, the converse. So it's a way of using risk stratification to make sure you get the right patients into the right place at the right time.
That does happen. We filter out the complex cases that go to consultants. So that does happen, perhaps in a less explicit way than you emphasise.
Yeah, I thought that was right. So I didn't think that was that. So it might just be worth checking that and looking at that, because I didn't think it would be 100%. And then it looks, in times that the world has moved on in terms of patients coming in through and the flow into theatre, and that certainly in Worcester you're managing 8 cases, although it says a bit variable in Hereford. So maybe can we just talk through that in terms of you're managing 8 cases in Worcester despite the case complexity. Is that right?
Yes, during the COVID period, when we were not, when we restarted, the numbers were down, but we have now come back to eight cataracts, and we don't have many trainings at all. So it's all consultant list. So yes, we are just going ahead and doing 8 cataracts per list, irrespective of complexity.
Yeah, that's very good. And what about in Hereford?
Well, I think the reason for the difference is that we have a lot of juniors. We have ST1s and ST2s most of the time. So that does put pressure on some of the lists. We also have a lot of problems with staffing in theatres and attracting good staff into Hereford, both the medical staff and nursing staff. So there have been a number of challenges from that point of view.
Yeah, and that's fair enough, and absolutely get that. And we've always said you might need to just amend the numbers a little bit for ST1s and 2s, but beyond that, no. You would get 8 cases would seem perfectly reasonable, and I get it's not just you know as a surgeon what you do; it's actually the whole theatre team. But I would say that I think that what we have found with putting in the pathways, and we've done high volume, low complexity, but there's also the converse, which is high complexity and low flow. So there's the other way around. Is actually that's really created momentum for people who want to come and work in these pathways, because it actually it's a really positive environment to work in and really dynamic, and people really like working in it. And we're really clear from a GIRFT perspective that you need to have dedicated ophthalmic theatre teams for this. We can't run these pathways with generic theatre teams, because to get the flow you need the skill, the experience, and the places that are running the high flow pathways, and also the 8 cases but high complexity will have dedicated teams. Ulrich, sorry.
I was just going to say that we have had, because of our RTT problems in the past, we have had Health Harmony coming in weekends, and I think I'd agree with the point about cherry picking, that a lot of the low complexity cataracts have been cherry picked. So we're all finding that the weekday surgery is very much sort of complex surgery with co-pathologies and so on. So I've done my own audits, and 10 years ago I would have sort of 30% sort of co-pathology. I'm a medical retina specialist, so a lot of diabetic cataracts, but now the vast majority, it's 90% plus that have sort of co-pathologies and more complex cataract needs.
Yeah, no, absolutely. And I think it's really focusing on the things we can change. So getting a really good pre-assessment pathway in place, starting on time, finishing on time, turnaround times, making sure you've got the right staff around you. And I'm conscious of time, actually. I've just noticed the time. So if we just move on, and we have talked a little bit about post-operative pathways already and patients being seen in the community. So I didn't know if anybody wanted to just make a comment about that, and then we'll move on to glaucoma. No, I think that's probably, of all the things of where to start with. If you haven't made any start anywhere with the cataract pathways, probably the easiest place to start is post-ops in the community, to be quite honest. Wojciech, I can't see you on the screen. Is there anything before we move off cataract? Is there anything else that you'd want to? No,
I would really back your last statement around post-operative pathways being a really good place to start, because it's very defined. It's very skills defined, it's very numbers defined, and that helps, and that sort of helps everybody being reassured in the system, particularly commissioners as well, because it isn't an open book. And the other point I think is hugely important, and I don't quite know what the situation is in these two areas, is around the dedicated theatre team and the and actually that issue of team building, which is so critical in getting the high volume through. But actually it looks as if we've achieved it to a large extent, which is really positive.
Brilliant, thanks, Wojciech. Before we move off cataract, does anybody else want to make any other comments about or ask any questions about cataract? Okay, the final point, actually, I just remember the final point. If you remember going back to the data
somebody else has come in. Aram. Oh, it's gone down now. Sorry.
Okay.
Hi, sorry.
Yeah.
Amin Sachdev here. I'm going to be one of the new consultants starting in Hereford soon. I just wanted to say that I did recently attend a virtual conference where Larry Benjamin was talking, and they have a fantastic risk stratification sheet that they use in Stoke Mandeville. I would be happy to pass that on to someone. I'm not sure whether, Alison, it would be best to send to you to then disseminate from there, but hopefully that might be of help. Just a suggestion.
I'd love, no, absolutely. I'd love to see it. And I think perhaps also share it with your new colleagues obviously in Hereford, but also in Worcester as well, because I think all of the things that we've written thus far that are all on our sort of GIRFT website or all the national websites or whatever, they're not meant to be written in tablets of stone. If people can find better ways of doing things, then everything should be added to amended, so that innovation is continuous. And I do know in Stoke Mandeville, Larry's colleagues Sarah Mailing and Mike Adams have done some really good work around lists that they call friends and family lists, which are for patients who do have, patients, for example, with dementia or something like that, more complex patients. And then Mike was saying that actually the lists are really, really popular. So hopefully he'll write some of that up for us fairly soon. Right, we'll move into glaucoma, and then glaucoma and medical retina are not dissimilar in many ways. So I think we can take, but the key elements in terms of running efficient, effective glaucoma services are just thinking about virtual, unless there is a and we'll check you're a glaucoma doctor, unless there's a very strong reason for a patient being seen face to face. So I can see there's some things within this sort of these metrics where we've got 0%. So in things like how are the patients risk assessed and potentially filtered in the community, so you don't just get a whole bunch of patients with possible glaucoma hitting the hospital and seeing patients face to face. That's really the past world, not the current, and well, hopefully what's not current, but definitely not how we need to go in terms of moving things forward. Again, this point about risk stratification and making sure, and then we can send them, or if that would be useful, models for risk stratification, so that patients are risk stratified into high, medium, low, variations on that type of idea, and so that we make sure that any patient who can be managed virtually is, and that the core group of patients who absolutely have to see a consultant are able to without coming to any harm. What I was really impressed by in Worcestershire, you're able to tell me how many delayed glaucoma follow-up patients you've got. The reason it's important to know what the number is, and in Hereford, I've just sort of, I think it's really important you get to the bottom to know what your numbers are. I mean, it's not great that the patients have been waiting that long, but at least you understand the size and the shape of the problem. What we really advocate is having fail-safe officers, and there's a variation in terms of what fail-safe. It could be as part of another administrative role, it could be a standalone role depending on the size of your department, and it could be a band 3, band 4, occasionally band 5 post. We've got job descriptions for that role if you haven't got those people in post, and it's their responsibility to make sure that all the patients who've delayed follow-up, they know where they are, and making sure that patients don't come to harm. We know that these patients are a particularly high-risk group. For one example, Western Eye Hospital, they have fail-safe officers by each subspecialty, and that really helps clinicians because it means the patients have got someone they know that they can contact, so clinicians we can get on with doing the clinical work without getting caught up and in trying to work out where patients need to be seen and what the risks are. And then one of the things that we are also advocating, and will be in the next iteration of this, is recording the earliest clinically appropriate date. It's a tab within your PAS system which can be activated, and it shows when we as clinicians think the patient should be seen next. And then from that you can benchmark how far away you are that. In terms of, I think possibly now at this point, I just throw this open in terms of Rachel, do you want to come in from your perspective?
Thank you. I mean, I think this looks really very interesting. What would be nice to understand is the relationships between the hospital provider and operos, and how the patients flow backwards and forwards, because that that sort of implies that your 488 is actually quite complex patients, or quite severely with significant glaucoma. I wasn't sure.
So this number will be largely in hospitalized services. During the COVID lockdown, what we did, all the patients which were in hospitalized services, we created a glaucoma register. We created the information of their vision, their pressures, their mean deviation, and the status of glaucoma. We created what was a intended follow-up, and on that basis, we risk stratified largely according to HUDUP classification of visual field defect, that less than 6 is mild, 6 to 12 is moderate. And then we also used, which we found a little bit more difficult, Glaucstrat fast classification by Shah as well. But for an ordinary ophthalmologist, we found it was much simpler to use HUDUP classification, and we stratified. And then all those 488 are perhaps in that category which were supposed to be green. So among all the patients of hospitalized services, we defined who definitely need to be seen within 4 to 6 weeks, which need to be seen within 3 months, and others were perhaps moderate glaucomas between 6 to 8 decibel of visual field defect. They are largely the one. Otherwise, all other complex, very advanced glaucoma, all have been seen. So nobody in that category is waiting.
Okay, so that's actually very heartening. How about and can I just go back to the first part of my question though? Is how does the flow between your community provider and yourself work, and are the appropriate patients being seen, and are you able to discharge that community provider if necessary?
So we have the direct electronic email system, and there is a fail-safe officer for last 1 year in our trust who is coordinating that. So there is one coordinator on our side, and we had emphasized when the operos was coming in that we do not want to be dealing with 2 or 3 different doctors. We just want a single point of contact. And if you need to send it to us, you send that to us on this particular email. Actually, we have streamlined all the referrals into ophthalmology in Worcestershire according to emails. If it is urgent, there is a separate for urgent care. If there is a cataract referral, there is an email for cataract referral, and for the glaucoma between operos and things, they directly refer to that fail-safe officer, and the appointment is then arranged for those patients.
Okay, that's good.
So it's managed.
And what about on the Hereford side? Is that there's a side is obviously a very different situation?
Because we're quite a small unit, or a smaller population, we have much more direct contact with the optometrists, and the optometrists provide the community service for us through a scheme called the COGS, Community Optometry Glaucoma Scheme. And they see all levels of glaucoma that is deemed as stable. So the cohort that we keep in the hospital are, obviously that hasn't fully run through, but the cohort we keep in the hospital are the ones that are changing. So the optometrists have a contract, have an arrangement that they see those patients on our behalf, and that's been hugely useful during the time. It has taken away a lot of that glaucoma workload from our hospital service.
And in terms of referrals, that and presumably the number of referrals you get has diminished, or the quality improved.
They go through a glaucoma referral refinement scheme on the same sort of process, and the referrals have stayed. I mean, we've had this in place for a little while now, so the referrals have stayed similar. But obviously, we have a backlog in new patient referrals.
And just my final sort of question on this, really, and is because you've obviously been working a huge length of time with these optoms, what I wondered is whether these are all still optoms working under core competencies, or whether any of them had higher qualifications.
So again, Darren has got his hand up. He will tell you.
Yeah, thanks, John. Yeah, so essentially, a couple of years ago, the local optical committee committed to some funding to raise the standards in glaucoma care amongst our community optometrists. So we funded the College of Optometrists Professional Certificate in Glaucoma and made that open to any practitioner working in the area, so that we could upskill them and broaden the horizons of our local community glaucoma management. So as John alluded to, we have an enhanced case finding service, all encapsulated by the COGS up front. So that hopefully reduces the number of false positives into the trust. And on the back end, the trust will discharge their stable glaucoma and ocular hypertensives into the community for us to monitor on a 6-monthly or an annual basis, with a very, very easy re-referral system back into the eye department, to the trust, if necessary. So yeah, we've committed to upskilling the community optoms from that.
And just to push you on that, Darren, what about IP and higher cert?
Yeah, so higher cert we haven't funded as yet, but we're always looking for ways to increase it. We had, prior to COVID kicking in, had initiated talks with the CCG about looking for funding to encourage the optometrists locally to get into IP. I myself have just gone through it, but funded myself. And we have about half a dozen IP accredited optometrists within the area. So not just, within glaucoma, it was very useful with regards to COGS and, during the COVID period and keeping patients out of the trust. But the problem with the IP and the higher certificate and the diploma in glaucoma is that they require a lot more dedication to time, and both outside of work and committing sort of maybe clinic hours to getting the relative sort of experience within the trust as well.
No, I think we're very cognizant of that, but I think you're in a very good position to actually develop that further.
Yeah,
relationship, because it's a sort of a relationships game, really.
Yeah, and historically, as I've said before, we have a very mature relationship in Herefordshire in eye health, and our optometrists are very motivated to support the trust. And yeah, as John said, it works both ways very much.
I think it's a very positive thing. Thank you. Alison, do you want to?
Can I just add into that the problem there is that there's no national contract for optometrists. So the optometrists, it's all up to various CCGs to arrange their own systems with their own optometrists, which is a bit sad, because optometrists are so important in the provision of eye health in the country. It needs to be something that needs to be looked at nationally and agreed nationally. The other thing to say is that these optoms have put in their own time and money into IP and into their various certificates, which has been absolutely fantastic for us. And we've only just been able to agree, well, only just about a year ago, I think, been able to agree that optoms have prescribing rights outside the hospital in the community. Which again, if you have IP and you can't prescribe, then there's absolutely no point, is there?
John, I think you're absolutely right, and we could have quite a long discussion about the things that we've been going through in Leicestershire about that. And I've got 15 higher cert optoms in glaucoma, and I struggle to find ways in which we can actually contract them. There is some movement going on nationally around that, and that's an open discussion within the restoration and recovery type framework, and hopefully it'll come forward. Thank you for that comment.
No, thank you. Thanks very much, and thank you. And yes, just to reiterate that within the National Eye Healthcare Programme, one of the as you would expect, there is clinical pathways work stream. There's also a commissioning work stream, and I'm clinical lead for that. So we're looking at what we can do from a commissioning perspective to remove all the potential blocks to make it so that it's as easy as possible for everybody to commission the right thing. So that's definitely happening. Shall we move into medical retina? I'm sort of conscious of time a little bit. In the main, in general, I would say, and Alric, correct me, and I don't know if other medical retina colleagues are on the call, but medical retina, there's been a lot of really good work done over the years, and your data suggests that's absolutely the case in terms of macular degeneration and diabetic retinopathy, in terms of the risk stratification work, thinking through what can be done, virtually probably the leaders in the field in terms of using virtual pathways and virtual networks. I think that in terms of, and it's good to see that you've got virtual diagnostic pathways in place, not just for M1, but for R2 and R3S. I think the point about hydroxychloroquine retinopathy screening in the community, that's completely, absolutely right. I completely agree. That shouldn't be done in the hospital. That needs to be done in the community. In East, my colleagues in East Kent have set that up and set it up very well. There's the documentation. So I just think from our perspective, we would completely support that. And I think it's just a question that does need to, because, you know, if you're strapped for space in the hospital, bringing patients, as we both know, I'm sort of bringing patients into hospital unnecessarily is a complete waste of time. So that might be something that could be moved on. I wouldn't like to say swiftly, but you've already got such a robust relationship with and good relationship with optometry colleagues that would seem to me something that could be moved on quite quickly if you felt that was a priority. And similarly, I'd say the same for Worcester, and it might be something that would be, if you're going to start building relationships with optometry colleagues, it's not a bad place to start. Because the structure and the framework's really clear, and it would sort of start building those elements of communication and trust, as John had alluded to. I was a bit in terms of just picking out something else, in terms of just thinking through, I can see the delays to follow up and so on. In terms of numbers of injections per session, I can see in Worcester that you're managing 16. How many per session do you manage in Hereford?
That's fewer. We're averaging about sort of probably around 11 to 12, and this is a sort of a I don't know if it's because nursing staff don't feel confident to do more. Certainly when I was injecting, I started the service, I started off as 12 per session, plus looking at OCTs, plus making decisions on the next treatment and so on, and all that takes extra time. So I think if you take that decision making away, and we've tried to do that now through COVID, we've introduced reviewers on each session so that the decision making's taken away from the injector, so the injector can just get on and inject. But we haven't managed to translate that into increased numbers of injections going through. We do have the facility to add in extras on the list, same day sort of treatments coming through the fast track pathways, so the sessions are not overbooked, but I think we've still got the issues with efficiency of throughput through the unit, because the unit has not been designed, you know, appropriately. It's a sort of, you know, we've got an injecting room here, we've got the injection suite outside, which is a little bit more streamlined, but it's still a compromise on what we'd originally envisaged. So we've never really had the I think appropriate facilities to provide a high flow service, and I would like to be able to offer more per session, and do that safely, but it's not been possible. One of the other things that we don't tend to do, and this is through my insecurity, if you like, about the risk of bilateral endophthalmitis. I know there's a big drive towards bilateral cataract surgery, and there's a big drive nationally towards bilateral injections, but I've been reluctant because of that small risk of bilateral blindness through endophthalmitis to introduce a bilateral process. And I think, you know, until you've got manufacturers routinely providing left and right packs with everything's different. Every you've got an easy way of ensuring that the only common factor is your patient. It's difficult to I find it difficult to justify bilateral treatment. So I think that will probably reduce our throughput and efficiency that way.
Yeah, no, thank you. And maybe if that would be we can always put you in touch with people who are running those types of services, so you could go and you could talk to, and hopefully before very long go and see those services just to talk through those issues, because I think they're very pertinent, and we all have to make our judgment around risk. And we set the number at 16 because it would seem to be a reasonable number for most people, and we had people doing 20 or more per session, and which we felt was probably going a bit too far. But I think, from what you're saying and accepting all the constraints you have, you've probably got a bit more flexibility to move that out, even within the geography and whatnot. So it might be worth just having a look at that. And I can see some hands up, and I'm sorry, is it? Mari, you might need to help me as to who was first. Sorry.
Yeah, I think Darren Smith. Sorry, Mary's just stepped out. I think Darren Smith was first, and then it's Mr. Misra.
Hi, I've made my point. That was regarding glaucoma. Thank you.
Oh, lovely. Thank you.
Oh, hi there. Yeah, I'm the medical retina lead, and Helen here is our lead nurse practitioner. So we're lucky, really. Our AMD and nurse practitioner team is fantastic. Actually, Helen has led a lot of the changes. So we actually doing 16 on our list, and obviously the bilateral ones as well for a number of years. We haven't had haven't had any endophthalmitis in any of those bilateral cases. Yeah, I mean, I think our main issues are with mostly the medical retina backlog, which was the huge issue. So some of the patients, we during the COVID times went through the list, as with glaucoma with Mr. Sharma, and we call it RAG rating, which is red, amber, green. And we stratified them, and so we're cutting through the backlog now hugely through our diagnostic clinic we set up in Princess of Wales Hospital in Bromsgrove, where we have 3 OCT machines and an Optos camera with lots of nursing staff, technicians, well, band 3, band 4 nurses, and band 5 nurses as well. So we are actually seeing a few hundred patients through there every week. The issue has been with reviewing these patients as they are going through the system, because we have not enough staff at the moment to review them quickly. So the main concern for us is the waiting time between the point the patient has gone through the clinic and the decision making. And that can be, initially we were planning our standard operating procedure. We set out that we would review them within 2 weeks, but unfortunately it's going on and on now. So it had gone up to 6 weeks, but we brought it down to 3 to 4 weeks now. But it's a persisting problem because we need to train up more reviewers. Our nurse practitioners are absolutely brilliant in the AMD side of things. They're completely different on them. Injections wise, virtually 100% are done by the nurse practitioners. And as far as the follow-ups as the AMD are concerned, the virtual clinics almost entirely by the nurse practitioners again. The only thing, the medical retina side of things, we are training up nurse practitioners to review, but we did discuss briefly whether to bring in an optometrist colleague in to do the reviewing as well, because I think they're pretty much trained already. So that's what we're looking at now. But I think compared to where we were before, I think we are doing a lot better recently with the backlog. As far as the new patients are concerned, we obviously stratified into the rapid access or fast track macular service. Generally, we're doing well with that. We got a one-stop injection for the new patients for AMD. So that cuts down the waiting time for treatment. The only other issues with follow-ups from AMD, which are relatively stable. These are the patients we need to discharge back to the optoms. And there was some initial talk with the optoms before the pandemic but it didn't progress. So that's where I think we'd like to see whether we can, the stable AMD monitoring, we can completely discharge back to the optoms. The issues are with the Heidelberg system, the optoms not having the same OCT system. And also, as Mr. Sharma alluded, it's currently we've got Open Eyes quite recently, and Open Eyes has been a problem initially because we chose to launch it, and then it happened that the COVID came along. So we couldn't really refine the system as much as we would want to. We are in the process of doing that. And I think once we get a link between the optoms and us with the IT platforms, then it'll be a huge improvement, hopefully, with the follow-ups.
Yeah, no, and I absolutely agree. And I think you're saying, you know, all the things you're saying and what you know, other people are doing and moving forward. And isn't it interesting, Alric? I was just thinking, where could I suggest that you visited in terms of learning about seeing, you know, bilateral injections or whatever else it might be? And as with most things, the answer's down the road, possibly. Okay, should we take one more question, and then I might stop us and just say, let's look at our 5 priorities because I am conscious of time. So is there another hand up? And I see, I can't see from my screen who's got.
There's Helen. There's Helen's from Worcestershire.
Yes, I just wanted to echo what Sam and Taryn and Helen have said. They have done a significant amount of hard work through COVID to stratify and to introduce, in effect, transformational change with the diagnostic approach. As Sam has said, you know, we've now got the diagnostics working really effectively as a one-stop, but the reviews, we've had some teething problems at getting the balance right. At the moment, yes, they've got it reduced down to 4 weeks behind, but I think it also masks some of the subtleties that we need to look at in the way of what commissioning and how we contract going forward, because what we're doing is a lot of one-stop where we're doing tests. We're then doing virtual reviews, and yet historically we were counted on attendances. So we're condensing the number of attendances, which in theory with the commissioning would reduce our income if we ever go back to that. And we're looking at how we make sure, and the discussions at senior level with the CCG about how we actually count this new way of working, because there's a major change. It's all good stuff we're trying to do, but we need to keep on top of what that is, because just the subtleties, like Helen is running on her lists for IVT, they also do an OCT on that visit. They then do a T&E virtual review following that visit. So that's 3, in effect, visits condensed, and our diagnostics are doing 4 tests, then are reviewed separately, remotely, which is not a face-to-face, instead of coming for maybe 2 visits for tests and then a face-to-face. So it's all the complications in that we're trying to work through, because it's all good stuff, but there isn't a clear path. And I don't know whether nationally you've identified a clear path of how we're going to record all this, and therefore the implications for contracting.
Yeah, so we are picking that up through the national, and that's why we've got national work and why we've got a commissioning work stream alongside everything else. So I'm very happy to take those specific examples back. But I think fundamentally we have to start with, we're doing the right thing for patients and the pathway, the commissioning and the big tariff, whatever follows that. But Wojciech is actually not only is a glaucoma doctor, he is an expert on all things tariff related. So I don't know if you want to.
I hear your pain, actually. And the answer is somewhere hidden in the depths of the system. There are ways of counting patients, obviously, and paying for patients from the old systems who are non-face-to-face, but it sort of doesn't apply as we've moved into block. My answer always to this is, yes, we're aware, but the reality is that if you have good relationships between the provider and commissioner, you can always get over this step, because the truth is the national structures and systems for counting and for commissioning and for payment are always going to be a step ahead of the people that are at the front end of actually providing innovative services. And there's a bit of sophistry sometimes creeps into this argument. So I think you can work through it within your within your local health community. And I think newer structures, ICS structures, will help that. The other point I wanted to make very briefly was around review and using optoms for review. There are several places that have actually got a lot of optom-led reviews, and actually just not even optom-led reviews, technician-led reviews of OCTs and so on. And I think we can put you in touch with those and to try to do that. It takes time to develop those skills, and you know, you've got to governance it properly. But they are a great boon when they're implemented properly.
Brilliant, thank you, Rochi. I think we better pause there, because that's been really helpful discussion. Taryn, I can see your hand up. I'll let you come back in a minute, but the exam question is, we need to, for Hereford and Worcester, we need to think of the system asked us for 5 priorities. So if we've talked about glaucoma, medical retina, cataract, interestingly, those are the things you prioritised were important. And Mari, I don't know if you want to take over here, but would people like to just come up with a couple of, why don't we do a couple from Hereford and a couple from Worcester, and just, because these have got to be your priorities. I can sit here and think that they're your priorities, not mine.
Yeah, thanks, Alison. I think that's really, and it's been a really helpful, interesting conversation. I think if we can get ideas from both place-based systems, that would be great. I think it's just aligning it to the challenge we've got of reset and recovery. Let's think, we're aligning what we've heard today. What would be our priorities to improve services so we can reduce the numbers waiting, we can put better clinical outcomes and better outcomes for patients, and make the best use of resources as well, because it's got to cover the three. It's got to cover the 3 areas. So should we start with Herefordshire first? Should we start with Herefordshire? And if you give us your top 2 priorities, what along what the discussions today have been, the GIRFT and best use of resources, and what would your top 2 priorities be? And we're not going to hold you to them forever, but let's get something down that we can take forward into our next steps for GIRFT.
I'll just repeat what I said about obviously needing bespoke, efficient space. Sort of just to reiterate, our unit was designed for 3 consultants, and we're now 8. So physical space, including sort of theatre suite, injection suites, and then obviously the manpower to staff that. So we need 2 theatre. Two lots of theatre teams, and more injection, more sort of more staff to do the review pathways and so on. So that would be my personal request. I know it's not it's high hanging fruit. It's expensive. There's a lot of capital required for that. Rather than the sort of low-hanging fruit. I think we've done a lot of work in Hereford to try and introduce sort of the easy changes that we can try and make. But and there's more we can do. But I think that's what I think our priorities would be from my point of view.
Okay, thanks, John Barnes. I just can see John's hand up.
Yeah, I mean, I couldn't agree more with Alaric. I think some of our challenges are really structural and really difficult to resolve. I mean, let alone the money and the space. Also, the time's a real issue to resolve this thing in the way that we would want to do. And we're certainly really supportive of providing the right environment for ophthalmology to do the brilliant work that they do. I guess what we need to do is find some sort of, at the same time as we're developing that plan and sourcing funding and etc., we need to find a solution to provide them with sufficient facilities now to manage in the interim, really. But that needs to be acceptable to the team. We've had that conversation with them already, and I know we're just about to approach them to talk about an ongoing fortnightly meeting to see whether or not we can't help them through some of these immediate concerns and resolve some of those issues for them. But I think support from the ICS, if there's an opportunity around additional resource, particularly things like mobile cataract units, etc., might be something that the team might be able to use. It's quite good to hear. I mean, I particularly worry about the hidden theatre challenge within our new outpatient waiting list, and an awful lot of that will convert to requiring surgery. At the moment, it's not sitting in our books, but it's absolutely there, and those patients will need treating as we start to see them through outpatient. So we need to resolve the outpatient problem, but then we'll need to resolve the theatre problem So I think any support we can get, obviously we'll do whatever we can ourselves, but any support we can get from the ICS would be really helpful.
Thanks, John. And now I've seen the numbers of the long waiters that we've just seen. I think I was texting Emily actually while it was going on, saying on Monday at Reset and Recovery, we need to be thinking, do we need a mobile cataract unit? You know, because otherwise this problem could take a long time, couldn't it, to sort out?
I just have to say we have to make absolutely sure that's clinically acceptable to the team. There's reservations about those sorts of facilities, and it maybe we have to do something else, but some sort of temporary fix where we can find acceptable temporary fix where we can find a much better long-term solution. But I think though a quick glance at the waiting times will not be scary. There is a much larger wait problem in the new outpatient waiting list than is currently visible. Right. And I'm really worried about what was we start to see those patients, and our theatre waiting list will become a lot more scary.
Okay, that's helpful to know. So, okay, we'll definitely pick that up, because there's a sort of short term, what do we do, isn't there? And then there's a long term sustainable, how do we deliver ophthalmology, particularly theatre services? That's really helpful. Thank you. That's probably big enough, I think, from Herefordshire, isn't it, to sort of to do that. So is it Ammon? Sorry, Ammon. And then Dr. Sharma.
Hi. Sorry about just putting a glaucoma spin on this as well. I'm sure that John Deutsch would might be able to fluff this out a bit as well. But from the perspective of more space and more infrastructure and so forth, if we are hoping to ultimately introduce a virtual glaucoma pathway, then again, that space and infrastructure just becomes more important to introduce. Because at the moment we don't have a virtual glaucoma system set up.
Okay, right. That's really helpful as well, and we'll make sure we capture that and add that to the list. So, Dr. Sharma, or Mr. Sharma, sorry.
Thank you. Just like Hereford, physical space is a limitation, and I think we did even consider a mobile data capture unit, like a mobile van, which captures data for AMD as well as for that data capture van for glaucoma, so that virtual glaucoma service or virtual AMD service can take place. But the biggest thing which I would like is now a bespoke, dedicated IT hub and frictionless IT transfer images. When you're reviewing the images, nothing is crashing, and sharing the data, reviewing the data. So perhaps a hub inside ophthalmology, so that we have unlimited IT space, effectively what I'm saying, so that the bandwidth power and the internet speed, all those things, in addition to the physical space can be tackled by mobile, not only mobile cataract. You should think of, we thought about mobile van with a cataract theater, an injection theater, as well as we thought of data capture for AMD and data capture for AM, and it came to about 500,000 per year for the hire of that van, and but that could do a very good job. But even then, we will require, the basic thing will be, future is in IT, future is in virtual clinics. So we need to have one is IT setup individually. Other, or what I would like from the national team, try to work out a kind of a single IT system, like either OpenEyes or whatever it is, that is to be taken by everybody, or at least the output for each IT system is exactly the same to be shared with others. So at the moment, Opros is working, they've got their own IT system, and that's what in my presentation I said, the IT integration, and ideally one system for all, and efficiently working rather than the frustration of working very slowly. Those will be my two things. Thank you.
Okay, that's great. Thank you. Really helpful. Helen?
Yeah, I was just going to add to that. The IT is absolutely imperative, but it's also the consistency of optoms. You've already heard Herefordshire have got a different relationship, different contracts possibly with optoms. And if we could, they are the future for how we move some of this diagnostic capacity. But all of us individually working our way round to sort that out does seem a painful way of doing it. And if we can actually have that done, because the CCG we work very closely with, and they're very keen to try and help this happen, but it would help if we could have some sort of a little bit opening, because working off GOC through region versus CCG with Optoms, and then us trying to do separate, it all gets very, very difficult, and we're trying to remove hurdles, not add them.
Yeah, well, I think you said that very well, Helen. It shows how we've progressed or not over the last 15 years, yeah, doesn't it? Okay, so yeah, I think that is a really, really important one. Ian, and then we'll have to close and decide next steps.
Yeah, it was just a comment and a reflection, and Alison hinted at it at the top of the meeting, is that there's a lot of good stuff happening in each of the providers and with each of the CCGs. And actually what I've heard today is that you've got quite a lot of learning and experience that could be shared across the whole ICS and system. So the comment you just made there, Helen, about the different contracting and the different relationships with Optoms between Hereford and Worcestershire, to me, part of today is about actually sharing that learning and then getting together afterwards and taking some of that forward in terms of what you think are the best bits in each part of the system.
Yeah, totally agree. And I mean, we are in probably a privileged position. We're now one CCG, although that happened in the middle of COVID, so it took over a little bit. So we can share the learning, and we've got an ICS structure emerging to support that. So given times and where people need to get away, thank you very much to everyone. That's been really helpful. And we've got the priorities there. We've got the information. Because this is one of 3 or 4 programs that we're doing for getting it right first time, there is a meeting between the Chief Operating Officer and the Chief Medical Officers next Tuesday, I believe it is, Emily, to decide how do we format the next steps, because we've all been in great meetings like this and felt the enthusiasm and got it all, and this is what we're going to do. And then, you know, there's so many priorities at the moment, there's so much to do, things get lost in the system. So I want to assure you we are going to persevere with this. We'll have another session locally with the clinicians and the most appropriate people, but we'll get out after next Tuesday's meeting how all that is going to work, so people are crystal clear how we're going to take this forward. There is one caveat in all of this, you know, we've got to show value for money. We've got to show that we are, you know, we're a system in financial, you know, difficulty, as many systems are. We've got to show that everything we do adds value, but is also doesn't destabilise financially our system. There's been some great, you know, examples of that today. I think the IT platform, we should be in in 2021 we should have an IT system that joins up you know, and provides that leanness for your clinicians. So, you know, showing investment to save is where we need to be. So, but let's just remember that in all the work that we do going forward. So thank you very much for everything, and particularly our regional colleagues and national colleagues. Thank you. Thank for the clinicians at the time and the senior execs, because it's, you know, where we're all very busy at the moment. So please, we will come back to you all after Tuesday with the comms of how we're going to take this forward and in what process we're going to do that and how we'll engage you in that process. Okay. Any final comments?
Just can these meetings be rotated to different days, because otherwise one person is taking out time exactly from the same activity, and that might be theatre or something. So it's very useful.
Good point. Yeah, good point. Emily, can we make sure the PMO takes consideration of that? That is a really good point. Okay. Thank you, colleagues, and we'll catch up soon with you. Thank you very much. Thank you.
Yeah, thank you. It's really great.
Thanks. Bye bye.
Take care.